I always tell you, everybody, again, thank you for joining us for the Appalachia Partnership Consortium. And look, one of the things I kind of always think is what's old is new and what's new is old. And I didn't think the thing that would be old and that's new again would be syphilis. I got to tell you. And so I wanted to tell people about what's going on with syphilis. Some people don't know that we're experiencing, I believe it's a global at this point, outbreak of syphilis. And I wanted to get two of the people that are the smartest people I know about this. We've got a national response, we've got a local response, but we know that our government is in fact responding. So I would like to introduce two people to you both, to introduce these two people to all of you. And I'm going to start because she got here first, Tim. Sorry, Dr. Harrison. Not is no other reason. Do you want to introduce yourself to the people? Ms. Footman, that's you. Yeah.
Yeah, I can. So hi everyone. I am Alison Footman. I am the Senior Program Manager for the STI Advocacy Program at AVAC. AVAC started off as an HIV advocacy organization, but over the past few years has started to include other topic areas, including STIs. We focus on several pathogens, including syphilis, and really highlighting the need for new STI diagnostics and vaccines.
And I apologize. I didn't refer to you as Dr. Footman, and I apologize for that. And it is Dr. Footman, so I want to apologize. And Dr. Harrison, you want to tell the people who you are and what your day job is?
Sure. Good afternoon, everyone. Tim Harrison here. I'm the Principal Deputy Director in the Office of Infectious Disease and HIV/AIDS Policy in the Office of the Secretary. What I'm not doing...
No, hold on. You chopped up... I interrupt all the time. They should have told you all that. But you chopped up the title. You said the Office of the Secretary. These people need to understand you're in the Office of the Secretary of the Department of Health and Human
Services. Yes. I'm sorry. I should be more
not the secretary, just running around taking dictation, but it's a pretty big job there, Dr. Harrison.
Right. No, my apologies. Sometimes the whole architecture of U.S. government is not all known. So Department of Health and Human Services and the Office of the Secretary, and then our sister big office is the Office of the Assistant Secretary for Health, which is led by the Assistant Secretary for Health, Admiral Rachel Levine. And we are one of several offices under her command. In my day job, when I'm not doing syphilis, which is a rare moment, HIV has been my lifeblood for the last almost 30 years, and much of that with the federal government, though I started out in communities in Chicago. But also more recently working on other issues from viral hepatitis to antimicrobial bacteria issues, all of it interconnected. Blood and tissue safety, vaccines, all of that. But lately, my primary job has been syphilis.
Thanks. Well, one of the things that we talk about a lot here, particularly on this call, is the growing syndemic, HIV, viral hepatitis, substance use disorder. But we also talk about the impact on economic development, workforce development, and other, many of us kind of are doing in our work. We kind of see that if for us to look at social determinants of health, poverty, et cetera, that if we don't do that, we really don't necessarily get to the root of a problem. But then we also have things like a syphilis outbreak, which impacts our work, but not all of us know enough about what's going on with syphilis, how syphilis is transmitted, how we need to be responding, and how we are responding as a nation. So what I'm hoping that who do I want? Which doctor? What do I want? I got so many doctors today. Who do I want to start with? I'm gonna call Dr. A. Okay, can I go? Is it okay to call you that, Dr. A? All right. So Dr. A, we're gonna start with you. Tell us, what is syphilis and why do we have this syphilis outbreak right now?
So syphilis is a sexually transmitted infection, and I think that syphilis is just such a fascinating infection because we did see a decline in syphilis rates in the early 1900s and the 40s before we had high syphilis rates. But then you saw penicillin, treatment, an antibiotic, come out, and it really helped to lower those infections, right? Syphilis is treatable. So it means once you get syphilis, you can treat it, but reinfections can occur. So you can get it again. But penicillin came around and it helped to treat these infections, which helped to prevent the spread of these infections. And it got to a point where people forgot syphilis was a thing. There are so many anecdotal stories where people thought that syphilis was gone. Healthcare providers didn't know that it was a thing. There were a lot of people who were like, oh, syphilis is part of our past. But over the past few years, we've seen this reemergence of syphilis cases to the point where there were some states who didn't have a single syphilis or a single congenital syphilis case, and now they're seeing more and more arise. And congenital syphilis is really thinking about syphilis among infants and babies. And so that is something that is really hard to swallow, for me at least, is knowing that we have an infection. It is preventable, it is treatable, but yet we are seeing these cases continue to increase among infants, and we're seeing infants and babies who are dying from this.
Now, if a congenital syphilis would mean the mother has syphilis when the child is born, correct? Am I putting these pieces together right here?
Yes, so a mother would have syphilis during pregnancy or when the child is being born. And even in that phase, syphilis is still treatable. So there are still ways to treat it and make sure that congenital syphilis or the passing of syphilis from mother to baby does not occur.
How do you do that? How would you prevent that? Just give an injection or of penicillin? Give penicillin pills? What's the treatment? What's the course of treatment?
So there's a specific type of penicillin needed in preventing congenital syphilis, and it is the benzathine G. I think Dr. Harris will be able to pronounce it a lot better than me today. But there is a specific type of penicillin that can help to treat congenital or syphilis during pregnancy. But what we've been seeing in the US and in a lot of other countries is that there is a short supply of that type of syphilis, which has made it even more difficult to treat and to prevent congenital syphilis. And while the US has done a lot of work to really circumvent this shortage, it did have a huge impact over the past few months on rates.
Right, because I know, if I remember correctly, I want to say I think West Virginia had got its first case of congenital syphilis, first new case. In this new iteration, in June, and I want to say I think that I got a call from Dr. Sally Hodder at WVU, where we're trying to figure out kind of what some of the next steps are. And I think Dr. Harrison, I then heard a presentation from you during the President's Advisory Council on HIV and AIDS in Houston about
Right.
what the federal response is going to be. So can you maybe tell us a little bit about kind of if it's a drug supply issue, what the government's plan is? Help me figure it out, because I got all these rural communities, that I got to educate about what's
Mhm.
going on, and then I got to get them access. So help me out.
Absolutely. I'll sort of take you back to August of last year of 2023, when the federal government convened and established the first ever, National Syphilis and Congenital Syphilis Syndemic Federal Task Force. And this is a task force that is helmed by Admiral Rachel Levine, and my office, the Office of Infectious Disease, coordinates the office on a day-to-day. And the reason that task force was set up is because over the prior year and a half, we've been hearing stories more and more about syphilis. even when we were there to talk about HIV when we traveled, we would hear, oh, by the way, I know you're here to talk about HIV, but we have a syphilis problem. And we were hearing different places from Southwest, Southeast, Northwest, from tribes. And so we were hearing this sort of call for, you guys need to do something, right? You need to pay attention to this. And particularly we were hearing the alarming rates of congenital syphilis. And Dr. Footman's absolutely right. The rates of congenital syphilis have skyrocketed. In some places, close to 800% increase.
So, So I told you, so I apologize for being rude, but I told you both.
No, this is a conversation.
That I always interrupt, because hopefully I hope that I'm asking the question that people want to ask you, and they'll jump in and ask questions in a minute, or they'll put them in the chat, which is what they can do. But so here's what I'm trying to understand: is it that there's a higher rate of syphilis amongst women, or is there a higher rate of syphilis amongst men, or is it parallel right now? Because you keep talking about this congenital syphilis rate, and I'm wondering out loud, or now I guess now out loud, not just in my head, is it that there are higher rates of syphilis amongst women, or there are higher rates of untreated syphilis amongst women, which is how we get to this congenital syphilis?
All of that. It's the short answer.
Okay.
The rates of primary and secondary syphilis have significantly increased as well among women, among MSM, among substance users, among a variety of different populations. So just overall, nationally, the rates of primary and secondary syphilis. And obviously it was said, you get congenital syphilis from a mother passing on syphilis to her child. And so we have been, while some of the focus for the task force has been particularly on the congenital syphilis angle, we can discuss the reasons for that. Primary and secondary syphilis among national populations, and in particular areas, is critically important too, because of the large increases. And the reasons for that are a mix, as we might, as you mentioned, as you started out, we thought we had solved syphilis, 20 years ago, the early 2000s. We thought, oh, syphilis is done. Well, like most things, what is old is new again, as you suggest. And here we are again with even worse rates than we had then. And so part of it, the ball, where, if you don't keep an eye on something, you're not vigilant about it, and understand that it is an infectious disease that can come back. But if you're not vigilant, it will come back. Lots of system failures in terms of how we invest resources and where those resources go, other things being prioritized. There's also, in terms of clinicians, people who provide care, large level of unawareness, of not being trained to detect, much less treat. And so missed opportunities across the board, missed opportunities. And CDC actually published a report basically on that, on missed opportunities, which says essentially that folks were not being diagnosed and or treated.
Now, so let me go, because okay, so I'm going to ask a couple of questions. We, like I told you, we take a syndemic approach here at Community Education Group, and many of the folks on this call are either providers who provide or harm reduction programs. Some of them are MAT providers, that's medically assisted treatment providers, community health centers, rural health clinics, that sort of thing. So one of the things, my big question for you is, and maybe I shouldn't ask this question, but this is why I do this, and this is why I do the job I do. Is it that we stopped telling people to use condoms and that we weren't vigilant about condom utilization? Is that where is I mean, we stopped talking about condoms in lieu of some biomedical responses? Is that how we got here? How we get here?
Dr. Footman, you want to start out, or you want me
I can start off. I mean, when it comes to condoms, we know that condoms are effective in preventing STIs. We know this, but there are also a lot of issues when it comes to condoms. People don't like using condoms. They don't find condoms to be fun or pleasurable. Also, in the US, we have access issues. There are some places where condoms are locked behind a door. So condoms are locked behind a cabinet. Condoms are an effective tool in preventing syphilis. They're not our only tool. And I think in HIV, the field does a really great job of understanding that there are different tools in the toolbox to prevent HIV infections. And that includes condoms, it includes biomedical interventions, it includes testing and treatment. And we don't have the same type of tools when it comes to treating syphilis. Syphilis, we love to joke about it, we love to talk about it, but syphilis is a really hard STI to work with. It is really hard to test for. When you test for chlamydia or gonorrhea, a test will come back positive or negative. When you test for syphilis, there's a lot more math involved in having to detect, is this an active case? So is it new? Or is this a case that was previously treated, right? Once you have syphilis, while it can be treated, those antibodies will stay in your system for the rest of your life. And that can make it really confusing for a lot of people in interpreting test results. And there are people who like to talk about how syphilis has been around forever, but the tools in detecting syphilis have also been around for forever. We don't have new tests that make it easy to detect this infection. And syphilis was something that people forgot about. And it's okay. People forgot about it. And sometimes that's okay because it was practically gone. But I think in forgetting about syphilis, it opened up a gap in care. And it opened up this gap where we weren't testing for it anymore. There were cases that were going undetected. And in this society, in this culture where you are having sex and you are enjoying this act, right? This is still pleasure. If you're not testing and treating, it opens a door for this infection to just spread rapidly. And that's what we're seeing. It's just a lot of people forgot syphilis existed and we weren't testing for it, which means we weren't treating for it. And we still don't have the tools to adequately test and treat for syphilis, which is why we continue to see cases increase.
Well, let's get into it then. Let's get into the test, right? Because we often talk about making sure folks get tested for HIV every 30 days, every 60 days, every 90 days, or annually. We say bring it up. But you really don't hear people talking about it. Make sure you get a STI screen when you go in there. Also, so what is the test and how often should people test?
I'll hand that to you, Dr. Harrison. I've spoken a lot.
There's so much flying through my head. But can I go back to one quick thing, though?
Yeah.
Yes, I want to go back to the condom thing. And I know I think it's a really easy thing to say, okay, there's not sufficient condom use.
Right.
As a reason for syphilis or other STI, and I get that, but I do think that the landscape is more complicated than that, and also the reality of how folks navigate sex across the board is more complicated than that. And so I don't think you just sort of say, well, people should be using more condoms, and then we would have no more syphilis or a reduction. I think it's more complicated than that. And you've already mentioned the whole syndemic issue, which I think is really a critical piece of this. You know, when you're talking about vulnerable communities, it's not just syphilis, as you know, that they're confronting. They're confronting a range of things, and I think the COVID pandemic was really illustrative of all of that. It really brought to the surface the whole syndemic issues of how communities are confronted. So there's that. The other thing I just wanted to mention, and is part of the complex landscape, is the treatment shortage issue, which was brought up. The long-acting bicillin, which is the standard care for folks who have syphilis. There was a shortage. Pfizer is the production company for bicillin. They don't really make a lot of money doing it. They had not been producing because syphilis was not really at the forefront. So there was clear shortage issues. That has changed, I will say. I'm really happy to report we have been in ongoing communications with Pfizer for the last year, and production levels that we've got them to increase production. And there really isn't a shortage right now. During the course of the last year, we even had CDC change some of their guidelines because of the shortage to prioritize using bicillin LA, long-acting bicillin, for pregnant persons and congenital syphilis cases, just so those because that's the only standard of care for those persons. There are other things like doxypet, that could be used for others to treat syphilis. We have now moved away from that. We're saying use the standard of care, bicillin to treat it. We also worked to have some imports brought in to treat syphilis, extensiline and lenticillin from outside imports brought in.
And when you say outside
from
imports,
outside the country, these are
you're saying,
treatment.
there are other
Right.
countries that have other treatment.
Right. That
Okay.
work just as effectively as our own bicillin. They came with their own little challenges in terms of cost and some other issues, but they were also as an alternative. But I will say today, as of September 9th, there should not be shortages in your communities around bicillin. And if there is a website the CDC has for you to notify them directly saying, we are experiencing some challenges getting bicillin, because there really should not be.
Okay. You got to slow down now. I know that's just the part. This is the part. I know you're gonna say this is the part where you should have let me use slide.
All right. Well, I can send all this stuff to you.
Right. But no. So we've got two questions, and one is, earlier you stated, Dr. A, you said that once a person has syphilis, he or she has syphilis, basically, or will show up get a reactive or positive syphilis test, and so the person asked, does that mean that you're still transmittable for syphilis? What does that mean? Can you take us through that a little bit further?
I can try. I'd say there are a lot more knowledgeable people when it comes to thinking about antibodies and syphilis, but really, once you have syphilis, it's not that you have syphilis for life, it's that those antibodies continue to show up in the system when you're retested. And a lot of times the confusion comes in kind of measuring those antibody levels, I believe, and understanding if it's an active or, not type of situation. And so so once you're treated, you cannot spread syphilis anymore. So you can't, but those antibodies will continue to show up within the test, which makes it really difficult for some people to understand if this is an active case or if it is a case that has previously been treated.
Okay. Now, the next question is the question about cost. You talked about cost a bit. So if I am in a Medicaid expansion state, I would imagine I go to my clinic, I get treated, it's covered. What happens if I'm not in a Medicaid expansion state and I've got no insurance and I find out that I've got syphilis? Is it because it's a communicable disease? It gets treated? Help me understand how do I get this paid for?
Yeah, we want to treat syphilis if you have it. So there's definitely every state should have the means to actively diagnose and treat syphilis. That said, it's not always done or not always done seamlessly. And depending on where you are, depending on the awareness of your providers and your payer systems. And, I participated in a southeastern collective of health departments and others. And part of the key piece of this was really trying to understand the payer system component of this, because it's really important. And it's complex. And I don't profess to be any expert on Medicaid and other systems and how they account for this, but definitely every state ought to be paying for the treatment of syphilis using the standard of care by selling. And in fact, we have our regional federal colleagues that have been monitoring that as well, and that we've been really intentional about not only understanding what we're doing, but what is sort of translating down into communities. And we've worked with ASTO, NACHO, and others to try to further sort of get the lay of the land experience for health departments, for community groups, for the individuals as they are encountering this. And so, yes, that should be covered.
So, all right. So help me understand. We're kind of at the halfway point in this call. I think we have an understanding of what syphilis is, where syphilis is, why syphilis is where it is right now. Right now, I'm gonna say it the way I would say it. I always tell people to think about this as you, me having a cup of coffee, and if you know me, you know this could go left real quick. So, what we gonna do? What we gonna do? Because it sounds like it's a problem. And so I've got folks that are somewhere along the harm reduction paradigm, some folks that are actively still using, some folks that are in various stages of recovery spaces. I've got communities that are rural. I've got communities that may not be as advanced in thinking about sexual behavior. Tell me what I'm going to do to educate these folks about uptick of screening, uptick of treatment, uptick of awareness. What's the plan?
I can start out. I can tell you what we've done and what our approach has been, and it's really kind of multi-pronged. I already referenced the treatment shortage issue, which is really important to address. Because if you're getting people diagnosed, we want to make sure that you can treat them. And so that was one effort. I think, we are vastly near complete elimination of any shortage issue. There's still some pockets we're hearing where there might be some issues, but we're addressing those. So that's one. Another big area of concern was just the providers themselves. Their awareness that syphilis is an issue, particularly if they're have not experienced that in the last 10, 15 years. Their training around it. As Dr. Footman alluded to, it is a difficult disease to sometimes diagnose. In fact, to diagnose, even more it's difficult to even treat. You may have heard the term the great imitator. That syphilis can present as other things, and it is very difficult. And there's algorithms and math to try to figure out the stage that you're in, whether or not you've had it. We would hope that you would remember if you were treated because of those needles, those significant needles that go in your hip or buttocks. And so the provider piece of this was really critical. So we convened a group of providers from urgent care, emergency rooms, perinatal, the full gamut of providers to talk about syphilis, and then have done significant follow-up with them to discuss what is your level of awareness, what are you seeing when folks come, what is your standard of care, do you test?
Dr. Harrison, so I want to jump in here and ask a question, because I think it's going to be a significant one. When you say provider, are you talking primary care provider? Are you talking, again, most of my folks, that touch point for them may not be a primary care provider, but may be a behavioral health provider at a MAC clinic, because, you know, a lot of MAC clinics started out as behavioral health providers, not necessarily PCPs. So help me, is there,
right.
yeah.
Many different touch points. And in fact, as part of the collective of federal agencies involved in this work, we have worked with the Substance Abuse and Mental Health Services Administration, or SAMHSA. And this is the federal agency.
Can you hear him?
Oh, can you not hear me? I'm sorry.
I can
All
hear.
of a sudden, I can't hear you.
Uh-oh. Can you hear me now?
I can hear you. Huh.
Oh, I'm
Yeah,
sorry.
I can hear you now.
Okay.
Okay. I don't know what happened. Okay.
No, but no, so you're right. So there are other touch points where we want to make sure that they're involved in this. And in fact, SAMHSA has been really instrumental. They have been at the forefront of what they can do in this fight. And they've done everything from a Dear Colleague letter out to all of their grantees to provide flexibility in terms of their grant funding and how they can address syphilis, and recognizing the intersection between substance use and syphilis. So no, you're right. It's not just your primary care providers. There are others who really, and I think in general, overall community provider awareness is really essential. You know, that people are aware that this is here, that this is an important issue that needs to be addressed. So the provider piece, I think, is in the training. You know, we've done a number of webinars that were provider focused, and I was struck at the level of the need for training and information about how to properly diagnose and treat syphilis. I didn't realize just how complicated it could be. You know, and we actually had to we hired as a consultant, a medical doctor who is actively working in clinics to provide that critical lens of that sort of client experience, you know, of how you bring someone in, and they may not come in thinking they have syphilis. They're there for something else.
Correct.
You know, and what you do. And so all of that is part of that landscape. And in some ways it mirrors some of the experience with HIV, you know.
So let me ask you this. Let me ask you, what can community folks do as a part of this response? Right? What can we be out in community doing? I know, you know, certainly we can do webinars like this to bring in our community partners, but what are the other things that we should be doing? Increase screening, increase awareness, talking about it. Tell me what we should actually be doing.
So I can jump in. I think it is incredibly important to talk about syphilis. I talk about syphilis all the time, even Thanksgiving, holidays. If you come to my house, you will hear about syphilis. If you come to my house currently, you will see those giant microbes around, and I have several in the shape of syphilis. I think it is incredibly important to talk about syphilis. I think that when you're talking about syphilis, especially in minoritized communities or communities that face a lot of stigma, it's important to note that no one deserves syphilis, right? Like, you're not getting syphilis because you're a bad person or you're participating in bad activities. I think there's a lot of stigma around STIs, especially nowadays, and especially with such little access to care. And so I think it's important that when you're talking to people, you really help to say, hey, syphilis happens and it can be detected and it can be treated, and you can go on with your life and participate in all of the activities that make you a happy and healthy human being. I think that that really has to be highlighted. We are in a fascinating time with syphilis right now because syphilis is a hard infection to deal with. It is a hard one to detect, but FDA has approved an over-the-counter syphilis test, and it should go on the market in a couple of months. And what I'm hearing is that it will be priced between $20 to $30. And I think what will be really interesting is thinking about the payer system and how it is that community orgs might be able to get access to these over-the-counter tests and provide that type of test to the people they're serving as an in-between, so that you're not having to go to a health department, you're not having to go to a clinic, you're not having to find a doctor, so that you can have that test and maybe have a conversation about syphilis with someone you feel a little bit more comfortable with than, having to then venture into the scary halls of a health department. And so I think as syphilis continues on, as we see these rates increase, we're seeing new technologies come out. We have to talk about syphilis. We have to talk about what tests are available. And as a community, we really have to examine what it is that our community needs when it comes to syphilis, how it is they would like to receive these services, what it is that they can afford, so that you can then go to your government officials to be like, this is how you can help right now.
Right. Okay.
Well,
So, do you see a world where outreach workers, community health workers are offering rapid HIV, Hep C, and rapid STI, or in this case, syphilis testing as well? Can you see that world?
So we already have that world in a lot of places in the globe. There is a rapid HIV syphilis test that is being administered to help detect cases. In the US, the infrastructure is a little bit different. So we don't always have access, or we don't always use some of those rapid tests. But we do have this over-the-counter rapid point-of-care test that will be available on the market soon, which is really going to expand our testing options.
Somebody said, "What about confidentiality?" What about confidentiality? And then I'm gonna start reading a couple of the questions that we've got down in the chat. Someone said, "Well, what about confidentiality?" And I think that they're meaning, I'm gonna try to interpret your question, whoever that was, in that if you have a rapid syphilis test, I think, are you asking the question about confidentiality with the community health worker, or are you asking about confidentiality beyond that?
Yeah, community, yeah, with so many people knowing your business more or less. In the, I serve a nonprofit, and I know that sometimes having students there, other people there, I really worry about trying to make sure that the patient, I'm substance there's a lot of confidentiality surrounding what I do.
Okay, correct. All right. So I think that, so most community health worker models have confidentiality agreements with the community health workers that are doing the outreach and that are providing the screening and that sort of thing. So I think the question is, when you get to the level where you've got HIV, STIs, Hep C, what is the bridge for confidentiality? Gotcha.
No, no, that's great. And I think, as Dr. Footman pointed out, the issue of stigma is real. And as someone who's worked in HIV for so long, I was struck by the level of stigma and shame that sometimes seems even more elevated in STI than it does for HIV. There is no one, someone said, there's no one sort of saying, oh, I'm living with syphilis.
Mm-hmm.
You know, there's lots of reasons for that, but you know, if you talk about rural communities, tribal communities, that level of proximity to people who will know your business is very real. And so the confidentiality piece, the protocols that must be in place, particularly as the technology sometimes can get ahead of us before we've actually understood how to really deal with it and with the issues of privacy and confidentiality, and being very mindful of that, I think is really, really critical. And for communities to helping to destigmatize sexually transmitted infections, because I will say, while syphilis is the focal point here, there are others that have increased as well over the last 10, 15 years, from chlamydia and gonorrhea to others.
That's, I mean, so I'm going to date myself a bit. But that's, like when I was coming up, you would go to what they called the drip clinic. You would go in there, you would get a shot, or you get your pill, and you come on out, and you saw who you saw, and you usually saw somebody you knew in there too, because if you were, they were too. So I mean, is it that we need to go back to where I mean, is it that stigma that we used to see with the quote unquote HIV clinic, and as many of these clinics have become FQHCs or primary care clinics, and so some of that stigma around HIV clinics is left? Is that what you think we might see now, or do we need kind of specialty care around this? Because I think it could go either way.
Right. No, there are a couple of ways I think you can approach this. I think in the HIV realm, there have been protocols in place to do the sort of STI screenings that are sort of expected, and when you're being tested. Not always done, but there are protocols in place. I think beyond, for those who do not enter into the prototypical sort of HIV realm, I think is where you're going to definitely have some challenges, where the decision to screen someone for syphilis can be a decision that's based on that client being there and the providers thinking, oh, you're not at risk. You're not at risk for syphilis. I don't need you. I haven't tested for syphilis in 15 years. What, not in this community. And so those decisions about who you screen become really important. And the decision making, are you in a low prevalence community where there isn't a whole lot of syphilis, but maybe you're a part of a, for lack of a better word, high risk population in a low prevalence community? There's all these sort of there's all these sort of calculations that a provider might make in terms of the decision to screen for someone. And if you're an average day person, you're not going in there necessarily thinking, oh my God, I need to be screened for all of these different things. That's not, particularly you're going in there because you have asthma.
Well, I mean, should we routinize STI screening the same way we've asked people to routinize an annual physical? We've asked them to routinize an HIV test. Should we not be routinizing screenings for STIs as well? I mean, what's the standard of care? I mean, is it that I'm supposed to get screened every year? I mean,
well, I mean, so much of it still is risk-based, unfortunately, when it comes to STI. It's risk-based screening. And during these periods now where we're seeing such a surge, there definitely have been made about, more routinized screenings. Certainly the case for those who are pregnant, childbearing, that's most definitely being screened 3 times. Early, mid, and then at pregnant, delivery. That and that should be the standard of care, and many have moved that towards that. That's absolutely. For everyone else, for sexually active MSM, who might be at more risk, should there be more screenings when they're having more HIV screenings to include. And we really are pushing the idea of this sort of combo plate of screenings, as you've talked about. You know, when you get an HIV screening test, you should have an STI screening test. You should get viral hepatitis. You know, all of that. You know, some will push back about certain populations being more at risk, so that's where it should be done. We don't have endless resources. It's a resource issue. But I think that calculation of how and when and how often, really folks need to take into consideration the current reality. You know, what's going on.
And current reality being the high rate of
High rates.
Okay, the high rate of syphilis. All right. So
Can
I'm going to ask somebody on the CEG team to pull out some of the, because I can't for some reason pull up the questions in the chat. So I'm going to let Dr. Footman respond here, and then hopefully y'all will come with the last couple of questions that we got. Go ahead. I'm sorry.
So I do want to add, you know, CDC has their screening guidelines that really lay out when folks should, you know, seek an STI test, whether that be on an annual basis for some of our young people who experience the brunt of these infections. They have guidelines for sexual and gender minorities. They do exist. It does not, you know, relieve some of the access issues, nor some of the stigma issues. And I do want to go back to some of the new testing modalities that we have. So we will have this over-the-counter syphilis test. And what is great about it is that community organizations could offer it. I can go somewhere and buy it for 20 to 30 bucks. But you can then take that test anywhere you want to. You can take it to your home, you can take it to your car, you can take it anywhere you want to, and you as a person can conduct that test on your own and get a result and know your status. You would then, if the test comes back positive, you would then have to have a confirmatory test in order to get treatment. But that option to this over-the-counter really revolutionizes our syphilis testing options so that it brings it to the person, to the end user, and they now have the option to have that test wherever they feel comfortable and, you know, or pick the test up from someplace and then take it and wherever they're comfortable. We also, for chlamydia and gonorrhea, we have self-collection kits. There is currently one self-collection kit that has FDA approval. It is expensive. It's about $100. It is referred to as the Let's Get Checked. And for this one, I think you can take a urine sample or a vaginal swab. You can take that sample, you would mail it to a lab, and then you would have your results within the next couple of days. And that is, again, another option where you can take that kit, you can collect your specimen wherever you feel comfortable, you mail in those results, and then you get them back. And I feel like some of these new techniques when it comes to testing is really helping to provide more of that confidentiality, and is definitely moving us to a space where maybe testing doesn't happen in a clinic and can happen in other places where folks feel more comfortable, and it can happen just in the safety and where you feel safe and comfortable. So I just wanted to bring up those couple of points for some of our new tests.
And can I say,
Okay.
no, just very quickly, I'm so glad you brought that up, Dr. Footman, because in addition to the privacy and confidentiality issues, the better diagnostics are also about equity and access. You know, increasing the possibilities for folks who might be more rural, who can't come in or don't have access to all the things that might be in terms of a clinic or a you know, a space that in an urban area where they would find care. It really does that. What we know is that there's so many missed opportunities where the connection between being diagnosed and being treated, there's a gap. And so this provides sort of shutting down or helping to reduce some of that gap in terms of providing folks more immediately that point of care issue. You know, and we actually came out with a point of care considerations document that sort of talks about how you can meet the immediate needs of folks who might be experiencing syphilis.
So one of the questions that's also in the chat is about the availability of social marketing, education, training materials. So I want to talk about from the what I call the end user, the me's of the world who are just out here in the world. What are the materials that are available for an organization like ours, or organizations like that are on this call to be able to either educate their members, to educate their staff, to educate their clients, their patients? What are, from the what are the tools that are available for local and county health commissioners or governments? And so, because we work with all of them, and so help me understand what are the tools that are available right now for education about what's going on for folks.
Well, certainly the CDC site has materials to go to. Just general informational materials on what is syphilis and all of that, but also campaigns that they have run around syphilis. The webinar series that HHS did, and actually other agencies did their own particular webinar series. Many of those resources are archived and really good information about syphilis. And I think really critical, you can use it at your own time, on your own leisure, to take a look at. Everything from what does syphilis even look like? Which was one of our webinars, which was one of the most well-attended webinars we've had. People were fascinated just to sort of see how it presents and at different stages. So there are definitely resources from CDC and other federal agencies out there. And I'm sure there are many local or state resources and other national organizations who provide resources.
I used to have on my desk when everybody was in offices, and I'm sure it's in a box somewhere right now, is that I used to have this syphilis spore that was like a stress ball. And I remember it so much because I remember always when I was use it because I was more stressed out. You remember back in the day, Tim, I was a little more stressed out than I have been on a mindful journey. But
yes,
I remember that, but I also remembered always thinking about how it was that syphilis was always kind of over here, this other thing that we talked about in the HIV space, or that we didn't talk about. So I'm even thinking of, like, is it that we need to bring more collateral like that back, the dancing syphilis spore, or something like that. It's like, I'm a bill on Capitol Hill, but no, I'm a syphilis spore and your rates are rising. Because I think that that's one of the ways that I think that the Appalachia region, West Virginia, with its HIV outbreak, for example, kind of got caught off guard. We were 30 years dealing with an opioid crisis and didn't, and then we had hepatitis C and didn't see that caboose of the train that I always like to talk about of HIV coming along. And now when I give that same analogy, I talk now about the idea of syphilis being a sidecar to this train that is kind of roaring through Appalachia, particularly with people with lived substance use disorder experiences. And I think that it's critically important that we do screening, but it's also critically important that we do education for our providers, but also for the individual consumer, so that people know to ask for the test. Because if you don't know to ask for the test and your provider doesn't know to ask for the test, then we're flying blind. And so,
and I would no, if I might just jump in just quickly, and I would go back again and emphasizing this whole syndemic piece, that lens. These things are not happening in a vacuum.
Right.
And the interconnective tissue between substance use and viral hepatitis and syphilis and HIV, mental health, all of that, particularly for vulnerable communities, poverty-ridden communities, insurance-challenged communities, all of that is in play. And so I think it really requires us to be really mindful of that intentionally, that the risk for something like this is more pervasive in these communities. And so we need to be attentive to that.
So we have
Can I-
about 4 minutes. And so I'm going to say, you got your last words coming to you.
I just wanted to add, so I love the CDC. I love the resources from our federal government. I, as a user, find them boring a lot of times. And I say this in the very chill way we're having this conversation. I think, though, that a lot of government agencies recognize how some of their resources are a little dry, which, bureaucracy is a thing that they have to abide by. But the CDC, they have several grants out right now where they're working with other community organizations and other nonprofits, and they are supporting some of their communication techniques. So I know one, for example, is the American Sexual Health Association. They've been doing a lot of communication campaigns for STIs overall. There is the National Network of Prevention Training Centers. They have a congenital syphilis hotline for healthcare providers. So if you have questions about congenital syphilis, they have a hotline you can reach out to get answers. I work at AVAC. We are a nonprofit. We have a website called stiwatch.org that we're currently updating to provide information about syphilis, but also new graphics. And we have co-hosted several webinars with a lot of other nonprofits, including NACHO. NACHO has some great resources as well. So of course, we always have CDC, we have our federal partners. They have really great background information. If it's a little too dry for you, there are a lot of other great resources as well. And anyone on the line, you can feel free to email me, and I am more than happy to share some of the links that I've been collecting.
That would be great, and we would get that out, not just to the folks on this call, but on the folks that have signed up for these calls in the past as well. Dr. Tim, your last word.
Wow. I would just sort of say, thank you for this opportunity to educate. This is all part of it. We want to raise awareness that this is here, that we are actively working to address it. If you're hearing about shortages around the treatment, please reach out. Do not let that go unattended, because that's one thing we think is definitely something we can address. But I think the education piece, as you alluded to, Tony, is really important. General awareness, general community awareness that this is here is important.
And someone just put in the chat, had we spoken about DoxyPep? And we have, but I'm going to let you both leave out on DoxyPep. Tell us about DoxyPep.
You want to go, or you want to go?
I'll let you go first.
No, just yes, that's an important drug for a variety of different reasons. Doxy post-exposure prophylaxis for treatment of sexually transmitted infections post a sexual encounter, and it's a wonderful tool in the toolkit. We have been promoting it. We're actually going to be promoting it even heavier in this upcoming year because it is an important tool. We did talk about it in terms of syphilis over the last year as a preventative tool. So no, it is absolutely important. You're going to be hearing more and more about it, particularly from the CDC over this next year.
Yeah, and we had Dr. Leo Moore on last month, and he spoke about DoxyPep in the context of STIs and other, and so we are very excited about the opportunity to connect the dots here. Dr. A, you got anything to go out on DoxyPep?
DoxyPep is a great tool for some communities, and I think it is important that DoxyPep has not been shown to be effective among all communities, including among cisgender women. And so when it comes to preventing STIs for chlamydia and syphilis, we still have a long ways to go in thinking about how we're preventing it for all of our communities that are impacted by these infections.
Well, perfect. I wanna say thank you so much for taking time out of, I know what are busy, super busy schedules for you both, to share your knowledge, attitudes, and beliefs around where we are with STIs, specifically syphilis, in this country. You know, and like I say, what I like to do is bring my friends, allies, and associates to bear on this region of the country, which often doesn't know that they can access people that are big muckety mucks like you guys at the federal government, and big muckety mucks at big giant global nonprofits like you are, but that are actually doing the work. And those are the people that come on these calls, are the people that doing the work. So I want to first of all thank you for doing the work, and I want to thank you for taking time out of your day. And we look forward to getting some information from you, and we'll pass it along to the folks that are on this call and others that have joined in the past. Again, thank you, and have an amazing week, and keep doing the work.
Thank you. This was a pleasure. Anytime.
Thank you for having us.
Ciao, ciao.
Yeah.